Now we're going to discuss Chapter 11, Suicide and Suicide Prevention. This is the recording for Chapter 11, Suicide and Suicide Prevention. Suicide is the act of taking one's own life. It is not a diagnosis or a disorder, it is a behavior. There are some populations that are at higher risk, and some diagnoses that a person has make them have a higher risk of taking their own life. Many religions do believe that it is a sin and it's strictly forbidden. In the field of psychiatry, suicide is considered an irrational act associated with mental illness, most commonly associated with depression. More than 90% of all people who attempt suicide have a diagnosed mental disorder. There's some discussion about the acceptability of physician-assisted suicide. Currently, there's about somewhere between 9 to 11 states, depending on what statistic you look at, that allows physician-assisted suicide. There are still many in our society that do not agree with this, and one of the problems or one of the disagreements that people have with physician-assisted suicide is that some believe that if you have a terminal illness, for example, you have the right to die with dignity, and then there's others that say that it's God's will to determine when we will die. Suicide is the second leading cause of death in Americans between the ages of 10 and 44, behind unintentional injuries. It's the 8th leading cause of death for those who are between the ages of 45 and 64, and the 10th leading cause of death overall. The last statistic that your book gives is that 47,511 people died by suicide in the United States in a year. Most of these were from firearm suicides. Many more people attempt suicide than those who succeed. So of those 47,000, the attempt to suicide ratio is about 12 to 1. So that is a huge number of people who have attempted suicide. And there are more that contemplate suicide without actually carrying it out. Unfortunately, we've seen a steady incline of suicide over a period of time, and this has become a major public health problem in the United States. There's also been a dramatic rise in suicide rates among military service members. There are some myths about suicide. The idea of people who talk about suicide do not commit suicide. In reality, 8 of 10 people who kill themselves have given clues or warnings about their intentions. So we need to understand what those clues and warnings are. When someone with major depression begins showing improvement, this does not necessarily mean that this risk of suicide is over. In fact, most suicides occur in the 3 months after they start to begin to show improvement. We shouldn't consider that this is an attention-seeking behavior. Everything needs to be approached with the idea that this is a possibility. See Table 11.1 in your book for more myths and facts. The suicide rate for single people is about twice that of married people. Widows and widowers have been identified as a group at high risk of suicide. Some studies found that divorced men were twice as likely as married men to die by suicide. Evidence has demonstrated that a change in marital status increases the possibility of suicidal behavior, particularly in the first year and particularly in older people. Elderly men who have lost their wife are at the highest suicide risk in the elderly, especially if they have been diagnosed with a health concern themselves. More women than men attempt suicide, but more men succeed. 70% of men who attempt succeed, and 30% of women who attempt succeed. The reason for this is that women tend to overdose, while men are more likely to use firearms or hanging. Women are also more likely to seek professional help or to ask friends for help than men are. Transgender individuals also have a high risk of suicide with a 41% lifetime prevalence. Affiliation with a religious group tends to decrease the risk of suicide, although it does not prevent against suicidal ideation. Religious service attendance is possibly a protective factor against suicide. Studies have found a decreased risk in both the general population and in those with mental illness, independent of any other factors. So having a religious affiliation is suggested to be a protective factor. Suicide rates are higher among individuals who have financial issues, unemployment, or those living in rural areas. Suicide in rural areas are those that are most likely to use firearms as a means. Farmers are a very high-risk group. Being a farmer is both very physically taxing, but can also be very financially taxing. Having previous attempts at suicide is a risk factor for eventual completion of suicide, so that's an important thing that we need to know when we're doing a risk assessment. White Americans are more likely to commit suicide than other races. Black, Asian, and Pacific Islanders have a lower rate. The majority of people who die by suicide have a mental illness, most commonly depression, bipolar disorder, or substance abuse. People who have been hospitalized for psychiatric illness have a higher suicide risk than others, particularly in the first week or month following their hospitalization. Early treatment with antidepressants is a risk factor for suicide, which may be surprising, but when someone is severely depressed and has suicidal thoughts, when they start to take antidepressants, it may give them more energy and take care of those vegetative symptoms that they've been experiencing. So the suicidal thoughts are still there, and it puts them at a higher risk because possibly before they started the medication, they didn't have the energy to complete suicide. But once they start taking the medication, those vegetative symptoms have gone away, but the suicidal thoughts are still there. Having a traumatic brain injury, problems with sleep, HIV, use of alcohol and barbiturates, psychosis with command hallucinations are also risk factors. We talked about schizophrenia and needing to evaluate anyone who's having hallucinations. If they're hearing voices, we want to know what those voices are telling them, because if they're telling them that they should hurt themselves, that increases their risk. Withdrawal from stimulus, a family history. If someone in your family has completed suicide, then you're more likely to commit suicide yourself. The CDC also says that youth in grades 7 to 12, LGBTQ youth, were 2 times more likely to attempt suicide than their heterosexual peers. About half of the individuals who kill themselves have previously attempted suicide. Loss of a loved one through death or separation is a risk factor. And in recent years, a number of suicides have been reported in the media among young people who are victims of bullying and cyberbullying. Suicide risk possibly has a genetic component. Some studies have found that there's a genetic association with some of the enzymes that are associated with the synthesis of serotonin. So diminished serotonin is found in people who have depression and suicidal behavior. So that kind of supports that theory. Neurochemical factors, so again, deficiencies in serotonin in the central nervous system have been associated with suicide, and that has been validated with postmortem evaluations. So when doing an assessment, we need to look at a person's age, their gender, their race and ethnicity, what their marital status is, what their social and economic statuses are, what their religious beliefs are, if they have family history, do they have a military history? All of these things need to be assessed when we're looking at suicide risk. We need to assess for different presenting symptoms, keeping in mind their medical and psychiatric diagnoses, especially mood disorders like depression and bipolar disorders. We also need to assess for suicidal ideations. What is the seriousness of their intent? Do they have a plan? And if so, do they have the means to carry out their plan? Do they have verbal or behavioral clues that lead you to believe that suicide is a possibility? These verbal and behavioral clues may be giving away prized possessions, getting their finances in order, suicide notes, making arrangements and pets, and a sudden lift in their mood. Sometimes that sudden lift of mood means that they've made a decision. Their interpersonal support system. Who is their support system? Has there been a change in their relationship? For example, are they going through an emotional crisis like a breakup or divorce? That can put them at high risk. So considering life stage issues, are they elderly? Are they young? Are they LGBTQ? Looking at the psychiatric, medical, and family history. Do they have someone in their family who was successful with suicide? That increases their risk of suicide. Having a medical problem themselves can increase their risk. Do they have unhealthy coping strategies, such as drug and alcohol use? Do they use mood-altering drugs? Are they feeling purposeless, like there's no reason to continue living? Do they have lingering feelings of rage or feeling like they're trapped? Are they feeling hopeless and expressing a desire to get away from others or withdrawing from others? Do they have changes in their sleep patterns, either sleeping too much or too little? Do they engage in risky or reckless behavior with no thought of the consequences, such as driving too fast? These are some things to consider. Strategies for enhancing the therapeutic relationship and talking about suicide. We need to be able to talk to people about this, as hard as it is to ask those questions. You will not make someone commit suicide because you ask them that question. If we feel that there's a chance that they may have suicidal ideations or are making plans, we need to come out and ask that question. There's a video in your module about the Golden Gate Bridge and suicide, and an officer there that is giving a talk about his experiences, saying that there are other ways to say this, and you don't have to straight out ask, are you going to kill yourself? His way of asking that is saying, other people who have been in a similar situation to yours have had thoughts of taking their life. Is this something you've been thinking about? This is called normalizing. Some nursing diagnoses include risk for suicide and hopelessness. What we want for outcome criteria is we want them to not have any physical harm to themselves. We want them to be able to set realistic goals for themselves, and we want them to be able to express some optimism and hope for the future. So what are some interventions? On a patient who is being discharged or who's in an outpatient setting, we want them to have access to a support system and to not be left alone if possible. We want them to have follow-up care and a detailed safety plan in hand. In the hospital, the patient safety plan is developed prior to discharge. The safety plan may include that they identify feelings and situations that cause them to need to be hospitalized. And then after they do come up with that, things that they can do to remain safe, like attending their follow-up appointments, taking their medication as they're instructed, attending therapy, socializing with others, enlisting the help of friends and family, and identifying who they're going to call if there's a problem. This slide talks about a no suicide contract. This has been mentioned in your book, but really it is a controversial idea, especially in the inpatient setting. If you make a contract with the patient and they say, I'm not going to do anything to hurt myself during your shift of these 8 hours, okay, that's all fine and dandy, but are you going to be paying much attention to them after your shift? And is that really beneficial, or does that just give the nursing and medical staff kind of false sense of security? And then for the client, what if they can't not hurt themselves? It's not like they really have a choice. Sometimes it's more of a feeling than a choice. And then there's guilt feelings of, I made this contract with my nurse and I said I wouldn't hurt myself, and then here I did. So that can just add to more of those feelings of making that person feel helpless and hopeless. The right approach when talking about suicide is to use a direct, matter-of-fact approach. Asking about thoughts, discussing any crises they're having, using active listening, letting them talk, and then antidepressant medications. So obviously as a nurse, you're not going to be the one to prescribe those medications, but if they are on them, you need to encourage them to continue to take their medication. We need to give them information about their medications and what to expect, what side effects may happen, and what they can do to mitigate those side effects. Someone who has had a lot of problems with suicidal thoughts and suicide may not get more than like a 3-day supply of medications and may have to go get their medication refilled every few days simply because there's a concern of them stockpiling medications to overdose. With anyone who talks about suicide, take it seriously. Don't decide that they're looking for attention. Don't keep secrets. If someone tells you about these thoughts, you as a nurse cannot keep a secret if the person confides in you that they're having suicidal thoughts, but they don't want you to tell anyone. You have to let them know it's something you must bring to their care team's attention. Be a good listener and let them talk. Sometimes all people need to do is to be able to talk, seeing that somebody cares about them and that someone is willing to listen and be supportive. Help them seek professional help. Know about the interventions for suicide. And while we're not going to actually restrict access to firearms, the state of Illinois does require that if someone is a danger to themselves or someone else, that it be reported so that if there is a request for firearms or if they have a current FOID card, that is possibly revoked for a while. This is one of the things that people who really like guns don't want to be in a mental health unit, and especially people who work with guns, they're very concerned about losing employment or losing access to their ability to have a firearm. If we're caring for family and friends of someone who has died by suicide, we want to encourage them to talk about the suicide. Don't discount their feelings. Don't tell them to snap out of it because that is not something that they can do. They need to go through that bereavement process, and we need to be understanding and supportive. Suicide is obviously a very difficult topic, and the evaluation is going to be continuous reassessment of the client and determining their achievement of their goals. Once the immediate crisis has been resolved, extended psychotherapy should be started. A suicidal person feels worthless and hopeless, and our goals for them would be to instill a sense of self-worth offering them hope and a meaning for living.